Immunosuppressants, they are classified as calcineurin inhibitors. Then second group is mTOR inhibitors. Third group is anti-proliferatives. Fourth group is glucocorticoids. And fifth group is the biological agents. Okay, am I audible?
Yes, sir.
Okay. So coming to calcineurin inhibitors, we have already seen about cyclosporin. Cyclosporin, it is a calcineurin immunosuppressant, and mechanism of action of cyclosporin, it attaches to a immunophilin, that is cyclophilin, and this cyclophilin complex, it binds to calcineurin and inhibits the activation of this calcineurin by calcium calmodulin complex, and this leads to the inhibition of the it leads to the dephosphorylation of the NF80, that is nuclear factor of activated T cells, and this decreases the transcription of the gene for the various interleukins, mainly interleukin 2. Interleukin 2, it has a special receptor, that is interleukin 2 receptor on the T cell, and the major antigen over here is CD25. So interleukin 2, which is released by the T cell, it acts on the T cell itself, and it may act on other cells as well. But by acting on this IL-2 receptor of the T cell itself, it can cause the activation of this CD kinases, and that leads to the progression of the cell from G1 to S phase. Okay, and in this, the major role is played by a protein which is known as mTOR. mTOR is mammalian target of rapamycin. Okay, so cyclosporin, it inhibits the calcineurin. Now cyclosporin can be given by oral route, as well as it can be given by intravenous route. Orally, it is having less bioavailability, that is 30%, and food decreases the absorption, metabolized by cytochrome P3A and excreted mainly in the bile. It is indicated for the solid organ transplants like liver, kidney, and it is second line in drug for autoimmune diseases like rheumatoid arthritis and psoriasis. It is second line because because of its nephrotoxicity. So what are the adverse effects of cyclosporin? We had already seen this in the last class. It is nephrotoxic, it is neurotoxic, it is also hepatotoxic. Okay, and also it causes the adverse effects like hypertension, hyperuricemia, hyperlipidemia, hyperplasia of the gums, that is gingival hyperplasia, and hirsutism. Okay, so this gingival hyperplasia and hirsutism, they can be these are the cosmetic adverse effects, and we should be careful in females. Okay, because you may give this drug for immunosuppression, and the problem of this cosmetic problem may arise. So remember all the H, and also one H is hyperglycemia, which is less because of because of the glucose intolerance. So remember all the H, which are the adverse effects of cyclosporin. Now coming to tacrolimus. Tacrolimus, it has a similar mechanism of action, similar adverse effects, only the binding site is different. It binds to the another immunophilin, which is FK binding protein 12. Okay, and by binding to this protein, it finally attaches to the calcineurin and leads to the inhibition of the calcium calmodulin calcineurin complex. Again, the dephosphorylation of NFAT doesn't occur, and that doesn't lead to the uh, production of the interleukins. Okay, so the mechanism is same, only the target is different. It is it has similar uses, but it is valuable in liver transplant, and the adverse effects like hirsutism, hyperuricemia, hyperlipidemia, they are less in comparison with cyclosporin. It is more likely to precipitate diabetes, that is hyperglycemia is one of the important adverse effects of tacrolimus. So you need to monitor the blood sugar levels, and it can cause alopecia, diarrhea, and neurotoxicity. Now coming to sirolimus. Sirolimus mechanism of action, it binds to FKBP12, that is FK binding protein 12, and it inhibits mTOR. Okay, the sirolimus was also known previously as rapamycin. Okay, so this R stands for ripamycin, that is the mammalian target of rapamycin, and this plays a role in cell cycle progression by activating the cell dependent kinases. Okay, and the T cells, they are arrested in G1 phase. Uses uses are same, that is it is used in acute graft rejection of solid organ transplants. It can be combined with cyclosporin, mycophenolate, and glucocorticoids. Now, one important thing is when you combine sirolimus with cyclosporin or tacrolimus, there is more nephrotoxicity. This nephrotoxicity is more when you combine sirolimus with tacrolimus. So this you should take care of. And sirolimus, it is also used for this coronary angioplasty. In coronary angioplasty, we put stents, right? So these stents, they are available as medicated stents, and the medication which is there in this, one of the medication is sirolimus. Why sirolimus is given? So as to prevent the angiogenesis, okay, so that there may not be a block once again. Okay, so the sirolimus eluted stents, they are very much used nowadays in coronary angioplasty. So this is a very important short note. Like you can be asked a short note on calcineurin inhibitors. That is, you have to write both cyclosporin and tacrolimus, or you can be asked a short note on cyclosporin, or you can be asked a short note on tacrolimus or sirolimus. So adverse effects of sirolimus, hyperlipidemia, bone marrow depression, leading to anemia, thrombocytopenia, leukopenia. Nephrotoxicity, it is less than cyclosporin and tacrolimus. And if you combine sirolimus with these drugs, tacrolimus or cyclosporin, there is bound to be more nephrotoxicity, and it causes delayed wound healing. Now coming to anti-proliferative drugs. Okay, anti-proliferative drugs, they are cytotoxic drugs, okay, or they are anti-metabolites. Cytotoxic drugs like cyclophosphamide, and anti-metabolites like azathioprine, mycophenolate mofetil, and methotrexate. I think all of these drugs you have already discussed. Do you remember them? Yes, anyone from the class?
Yes.
Okay, which drug do you remember?
Methotrexate and
Yes,
cyclophosphamide. Methotrexate, cyclophosphamide.
methotrexate and cyclophosphamide. Yes, in cancer chemotherapy, you must have
Yes.
discussed those two drugs. Okay, so apart from anti-cancer drugs, methotrexate and cyclophosphamide are also immunosuppressant drugs. Methotrexate, it is used in rheumatoid arthritis. Okay, it is a disease-modifying anti-rheumatic drug. Cyclophosphamide, again, this is a cytotoxic drug used in cancer, as well as it is used as an immunosuppressant in or in organ transplants, but it has limited utility because of its adverse effects. Okay, so it is not a first line drug. The adverse effect of which adverse effect is seen with cyclophosphamide?
Acute
Yes, the adverse effect commonly seen with cyclophosphamide, which is very important, is
acute
hemorrhagic
tubular necrosis.
nausea,
cystitis.
nausea, vomiting, loss.
Nausea, vomiting, they are the common ones,
Hemorrhagic
right? Seen
cystitis.
with any anti-cancer drug. Nausea, vomiting, bone marrow depression, alopecia. Okay, so those are the common ones because the anti-cancer drugs, they generally they inhibit the rapidly dividing cells, and that is why bone marrow depression, alopecia occurs. But the important adverse effect of cyclophosphamide, which you should remember, is hemorrhagic cystitis, which is because of the metabolite. Okay, cyclophosphamide is metabolized into two main metabolites. One is aldophosphamide, which is responsible for the action, and second is acrolein. Okay, so this acrolein is an irritant, and it is responsible for hemorrhagic cystitis. Which drug you give for treatment of this hemorrhagic cystitis?
Mesna.
Mesna. Excellent. You give Mesna. Okay. What is mechanism of action of methotrexate as an anti-cancer drug? It acts as a dihydrofolate reductase. Okay, it is a dihydrofolate reductase and a anti-metabolite. Okay. Coming to azathioprine. Azathioprine is a purine analog. Okay, you know purine analogs like 6-mercaptopurine, thioguanine, they are used in cancer chemotherapy, right? So azathioprine also is a purine analog. The interesting thing about azathioprine is not used as an anti-cancer drug. Its use is mainly as a immunosuppressant. Okay, so azathioprine is a prodrug. It is converted to the active form, that is 6-mercaptopurine and then to 6-thioguanine. Okay, and this conversion takes place in the lymphocytes. That is why it mainly acts as a immunosuppressant and not as an anti-cancer drug. The 6-thioguanine, it is firstly incorporated in the DNA of the lymphocyte, and that leads to the formation of the damage of the DNA, and you get dysfunctional lymphocytes. So this is the mechanism of action of azathioprine as a immunosuppressant. Okay, in between, if I am not audible or if there is some problem, you can always tell me. Okay. Azathioprine, it is used for renal graft rejection, and also it can be used for rheumatoid arthritis. Adverse effects, just like the cytotoxic drugs, it is having bone marrow depression, alopecia, and it can also cause hepatotoxicity. Okay, so azathioprine, it can be combined with the other drugs, like it can be combined with glucocorticoids. Okay, for the treatment of renal graft rejection. Now coming to methotrexate. Okay, methotrexate, it is having multiple uses. It is an anti-cancer drug. Also, it is a immunosuppressant. The exact mechanism of action of methotrexate is not known, but what is postulated is it increases the adenosine levels. Adenosine is a potent endogenous anti-inflammatory, and it inhibits the superoxide anion generation in the neutrophils. Also, methotrexate decreases the cytokine production and enhances the apoptosis of activated T cells. Okay, so this is the mechanism of methotrexate only as a immunosuppressant. Okay, sometimes methotrexate is asked as a short note. Okay, so don't forget that methotrexate primarily we use it for cancer. So you have to write methotrexate as an anti-cancer drug. There you have to describe the mechanism of action, that it is a dihydrofolate reductase inhibitor, right? And then you can add the immunosuppressant actions of methotrexate, then the uses of methotrexate. So methotrexate, what is its use? Where is methotrexate used? Can you tell me some of the uses of methotrexate? Methotrexate is curative in
It is used in and as antibacterial
choriocarcinoma.
to
Okay, it is one of the drugs which is it is curative in choriocarcinoma. It is used for rheumatoid arthritis. Okay, it is used for uh, termination of pregnancy. So there are multiple uses of methotrexate. What is the adverse effect of methotrexate?
Folic acid deficiency.
Yes,
Folic acid deficiency.
like any other um, folate inhibitor, okay, it can cause megaloblastic anemia because it inhibits the formation of the active form of folate, that is tetrahydrofolate, by inhibiting dihydrofolate reductase, mainly in the
reductism.
cancer cells. Okay, so it has more affinity for the cancer cells. And what is the treatment you give for preventing this adverse effect
Folic
of
acid.
megaloblastic anemia?
Folic acid.
You give
Administration of
folinic acid.
leucovorin. Leucovorin. Folinic acid.
Folinic acid is also known as citrovorum factor. Okay. So if citrovorum factor is asked to you, don't get confused. It is same as folinic acid, which is used in treatment of, which is used for prophylaxis of megaloblastic anemia when you are giving methotrexate. Now
Leucovorin.
coming to
What is this?
mycophenolate mofetil. So this mycophenolate mofetil, it is an antifungal. It is a prodrug of mycophenolic acid. It inhibits the enzyme inosine monophosphate dehydrogenase 2. Okay, so this enzyme, that is inosine monophosphate dehydrogenase 2, is inhibited. And this inosine monophosphate dehydrogenase 2, it plays an important role in inflammation and release of the cytokines, and also uh, there is decrease in the guanosine synthesis because of this mycophenolate mofetil. This guanosine, it is required for the synthesis of biopterin or tetrahydrobiopterate. Okay, so this biopterin, it is a main, it is one of the components of INOS. What is INOS? INOS is inducible nitric oxide synthase. So when this INOS, when there is increase inducible nitric oxide synthase, there is increase in the release of nitric oxide, which is again a inflammatory mediator. Okay, so by inhibiting inosine monophosphate dehydrogenase, mycophenolate mofetil acts as a immunosuppressant. It can reduce both the cellular immunity as well as humoral immunity. Cyclophosphamide, as an immunosuppressant, it has more marked effect on the B cells and humoral immunity. It is used for treatment of rheumatoid arthritis, SLE, pemphigus vulgaris, and idiopathic thrombocytic purpura. But you should take care that it is having toxicity, and it should not be given as a first line drug for these conditions. Short course therapy can be given for the acute bone marrow transplant, and adverse effects are cystitis, that is hemorrhagic cystitis, for which we give mesna. And it is this hemorrhagic cystitis is because of the metabolite acrolein. Now coming to glucocorticoids, I think glucocorticoids you must be well aware. Okay, we had at least two lectures on glucocorticoids, so you should know the mechanism of action. Can anyone tell what is the mechanism of action of glucocorticoids? Glucocorticoids, they act on which receptors? Yes, am I audible? I think there is some problem with the audio. I will change my earphones. Yes, now is there any problem? Can you hear me? Yes. Am I audible?
Yes, sir. You are perfectly audible. You were audible actually.
No, because I didn't hear any answer. So I got confused. So I thought maybe I am not audible. So
No, sir. You are audible.
when I ask question, everyone goes mute. Okay, so what is the mechanism of action of glucocorticoids? Can anyone answer?
They have an anti-inflammatory action, decrease
No,
arachidonic acid synthesis.
mechanism means at the level of the receptors. It acts on the glucocorticoid receptor. Glucocorticoid receptor is a cytosolic receptor, right? You remember the structure of the glucocorticoid receptor in the initial pages of your
Yes,
Tripathi,
sir.
given along with the
Yes, sir.
pharmacodynamics, right? So uh,
Yes, sir.
there is presence of heat shock protein 90. When the glucocorticoid enters the cell, attaches to this cytosolic receptor, heat shock protein 90, it is dissociated, and this sets the glucocorticoid receptor free, right? And the glucocorticoid
Yes, sir.
receptor then goes inside the nucleus, and in the DNA where there is glucocorticoid responsive elements, there it binds, and it is responsible for the co-repression and stimulation of certain genes. Okay, and that is how it acts. That is, there is increased synthesis of some proteins, decreased synthesis of some proteins. So glucocorticoids, they have a marked effect on cell mediated immunity, and they have action on prostaglandin synthesis. Okay, they decrease they decrease this arachidonic acid synthesis, they decrease the cytokine production, interleukin 1, interleukin 2, interleukin 6. Many of the interleukins, their synthesis is reduced. They also decrease the expression of MHC, that is a major histocompatibility complex. Its expression is increased on these cells. And glucocorticoids, they have multiple uses. I think they are the drugs in your Tripathi which have the maximum number of uses, right? One of the use is to prevent the graft rejection. Okay, whenever there is accelerated or acute graft rejection, The treatment of choice that we give is glucocorticoids, that is methylprednisolone, given for 3 to 5 days intravenously daily. Okay, so whenever there is acute graft rejection or accelerated graft rejection, then we give this glucocorticoids. Also, they are used for induction therapy as well as maintenance therapy for the graft rejection, and in autoimmune diseases like myasthenia gravis, rheumatoid arthritis, and many other autoimmune diseases, these glucocorticoids can be used. So this is the table from Tripathi, which I have taken from glucocorticoids chapter, right? Number of anti-inflammatory and immunosuppressant actions of glucocorticoids. Okay, remember a few. One is decreased production of prostaglandins, okay, by acting on the membrane phospholipases, that is, it inhibits the phospholipase A2. Phospholipase A2 is this phospholipase A2 is inhibited. So the initial step in the synthesis of prostaglandins, right, that is the release of the arachidonic acid, that is inhibited. Then another important action is on MHC. The expression of MHC is reduced. Then they also have action on various other inflammatory mediators, acute phase reactants, decreased production of endothelial as well as intracellular adhesion molecules. Okay, so this is just to show you that they have numerous immunosuppressant action. Now, adverse effects, this is out of the scope of this topic. I have just put it here so that you remember it in an easy way. Okay, remember the mnemonic glucocorticoid, and based upon that you can remember the adverse effects of glucocorticoids. Okay, they have a number of adverse effects, just like their uses: glaucoma, muscle atrophy, peptic ulcer, Cushing syndrome, osteoporosis, etc. You can go through them later on. I will share you these slides later on. You can go through them. Now, coming to biological agents. Okay, so biological agents, they are tumor necrosis factor alpha inhibitors like etanercept, infliximab, adalimumab. Okay, this etanercept, it can inhibit both TNF alpha as well as TNF beta. Okay, and that is why it is not so much preferred, because by inhibiting the TNF beta, it will again cause the stimulation of the T cells, and it is not a good drug. Infliximab, it is selective for TNF alpha, and adalimumab is the newer drug. Okay, you can see over here there are many monoclonal antibodies over here. Okay, what is a monoclonal antibody? Monoclonal antibody is an antibody which is directed against a particular clone of
particular type of antigen.
yes. So it has it is directed against a particular antigen only. Okay, and polyclonal antibodies, they are directed against many antigens. So monoclonal antibodies, all the monoclonal antibodies, they end with MAB. Okay, so infliximab, adalimumab, daclizumab, basiliximab, tocilizumab, muromonab, they are all the monoclonal antibodies. Remember that when a prefix, the prefix may vary. There may be a prefix O, there may be a prefix XI, there may be a prefix UMAB, or there may be a prefix ZUMAB. Okay, so OMAB is the monoclonal antibody which is murine. Okay, OMAB is murine, that is mouse, obtained from mouse. ZIMAB is chimeric. What do you mean by chimeric? It is part human and part mouse. That is part of the mouse antibody, that is around 25%, and about 75% of the human antibody. What is UMAB? UMAB is human only. Okay, so least allergic reactions, they occur with UMABs. Okay, and ZUMAB, it is the humanized murine antibody, which means that more amount of human antibody is there, 90% or more, and less amount of murine antibody is there. So ZUMAB, it has again less antigenic reactions, but it has more antigenic reactions than UMAB. And OMAB, which is obtained from the murine source, it has the maximum. Okay, so TNF alpha inhibitors, uh, also the interleukin 1 receptor antagonists, they are mainly used in treatment of rheumatoid arthritis. Okay, so infliximab, what is the source? It is chimeric. That is, it is having mouse antibody as well as human antibody. Okay,
Human.
yes. And adalimumab is human antibody, human monoclonal antibody, and it will have least allergic reactions. Now, interleukin 1 receptor antagonist is anakinra. So, anakinra is used in treatment of rheumatoid arthritis. Interleukin 2 receptor antagonists. So, interleukin 2 receptor antagonists, they are mainly directed against the
T cell activation.
CD25 antigen. Okay, the IL-2 receptor present on the T cells, mainly the CD25 antigen is there, and this daclizumab and basiliximab, they inhibit this interleukin 2 receptor, and they are also known as anti-CD25 monoclonal antibodies. Daclizumab has less affinity to this interleukin 2 receptor than basiliximab. Now, IL-6 receptor inhibitor, you must be hearing this tocilizumab very much nowadays. Okay, everyone is running after tocilizumab. You know why? Yes, what is the reason? Why suddenly there is a renewed interest in tocilizumab?
COVID-19.
COVID-19, yes, the burning topic. Okay, so tocilizumab very much used nowadays in COVID-19 patients, okay, who are serious, and it is mainly to prevent the cytokine storm. Okay, the cytokine storm, it is said to be responsible for more morbidity and mortality in COVID-19 patients. Therefore, this tocilizumab is being used a single dose for COVID-19 patients. Anti-CD3 antibody is muromonab. Okay, so muromonab, it is a murine antibody, and it is targeted against the CD3. The CD3 antigen is present on the T cells, and whenever there is the presentation of the MHC along with the peptides to the T cell receptor, the signal, it is sent to CD3, and CD3 further transduces this signal, and which is then translated and transcribed to the formation of interleukins. Okay, so this is a very old antibody which was synthesized in 1980s, but still it is used. It is used for induction therapy along with corticosteroids, and adverse effects it can cause flu-like syndrome, okay, and also pulmonary edema, that is some fever, myalgia, it may be seen. Also allergic reactions, hypersensitivity can be seen with muromonab because it is a murine antibody. This is a list of other monoclonal antibodies. Luckily, you don't have MCQs in your final exam. Okay, otherwise, uh, these are the burning questions which are asked in the pharma exam. They give you any one of this name of the drug, and you are asked what is this and what is this monoclonal antibody, right? So important ones among these: interleukin 12 inhibitor. Okay, that is ustekinumab, used in psoriasis and multiple sclerosis. IgE antibody, you already know omalizumab, which is used in bronchial asthma. Anti-CD20. Okay, this CD20, it is antigen is present on the B lymphocytes, and the drug rituximab, uh, it inhibits this CD20, and therefore it is used in the CD20 positive non-Hodgkin's lymphoma or CLL. Okay, natalizumab, used in multiple sclerosis. It is a alpha 4 integrin inhibitor. This alpha 4 integrin, it helps in the attachment of the T cells. Okay, and multiple sclerosis, you may be knowing that it is a autoimmune disorder, and the antibodies, they are targeted against the myelin basic protein. Then you have anti-CD80 or anti-CD86, okay, which plays a role in co-stimulation. Okay, we have studied the concept of co-stimulation in the previous class. So for co-stimulation, either this CD80 or CD86, which binds to the CD28 antigen of the T cells, or CTLA4. What is CTLA4? CTLA4 is a suppressor. Okay, it is not a stimulator, it is a suppressor, right? And similarly, PD1, that is programmed death protein 1 inhibitor, nivolumab, which is used in metastatic melanoma. Now coming to the polyclonal antibodies. Okay, polyclonal antibodies, two examples which are asked to you in your exams. One is anti-thymocyte globulin, and second is anti-D immunoglobulin, that is Rho-D immunoglobulin. So this anti-thymocyte globulin, it is purified polyclonal antibody, which is obtained by injecting the antigen in the horse or rabbit. That is the thymic lymphocytes, they are injected, and the globulins which are obtained, which can be used to prevent the acute graft rejection in steroid resistant cases. Adverse effects, it can cause anaphylaxis and serum sickness. Now coming to anti-D immunoglobulin, okay, which is also known as Rho-D immunoglobulin. So you must be knowing about the blood grouping system, the rhesus blood grouping system. Can anyone tell me what is positive and what is negative?
Yes, sir. RH antigens are present on the RBC along with antigen A, B, and O. So basically, RH
So
positive and RH negative.
okay, so we are concerned here only with RH positive and RH negative.
Negative.
So if RH positive is there, that means the antibody is, will there
Antibody
be
is absent.
in the antibody is absent. Very good. So if RH antigen is present in the body, RH antibody will be absent. And if RH
Yes, sir.
antigen is not present,
Yes, sir.
okay, and
Yes.
you give the blood which is RH positive, what will happen? There will be
It will
production
produce
of antibodies targeted against these, and there will be hemolytic
Acute
disease.
reaction.
Okay, so RH incompatibility. So this is mainly important in pregnancy. Okay, Uh, Imagine a O negative female, okay, and she has the baby or a fetus which is O positive, okay. So during the first pregnancy, she will be exposed to this positive antigen, and there will be production of the uh, antibodies against this Rh positive antigen, and it will be stored in the memory. So in the next pregnancy, what will happen? There will be abortion or destruction of the fetus. Okay.
Yes.
So what do? We give RHD immunoglobulin or anti-D immunoglobulin. Okay, so this RHD and RH rho D immunoglobulin is given within 72 hours of the delivery of the first child, because we want to neutralize all the antigens, right? So also it can be given when there is abortion, and some of the obstetrician gynecologists, they give it in the last trimester also. This is to prevent the hemolytic disease in the future offspring. So the dose, it is 250 to 350 microgram intramuscularly, and it is the treatment of choice to prevent the hemolytic disease in future offspring of a Rh negative mother. Now, what are the regimens for immunosuppressants? Okay, you have a induction regimen, that is when you have done a organ transplant. You begin with the drugs, two or three drugs in combination in high doses. Then you have maintenance regimen, where you decrease the dose of drug and you continue it for a long period of time. In between, you also have the regimen for acute rejection. Okay, that is if there is accelerated rejection or acute rejection during the treatment, then you have to give the anti-rejection regimen. So induction regimen, it starts with the transplant, and you should give it for 2 to 12 weeks after it. Most commonly, we give three drugs in the combination. You can give cyclosporin or tacrolimus or sirolimus along with prednisolone and mycophenolate mofetil. Okay. The the kidney sparing regimen. Okay, because cyclosporin and tacrolimus, they are nephrotoxic. So kidney sparing regimen is a regimen where we use sirolimus along with prednisolone and mycophenolate mofetil. Okay, so this is the induction regimen which is given at the start when you perform the renal transplantation or any organ transplant. Initially, for up to 3 months, you have to give a induction regimen. Then you shift to the maintenance regimen, which is given for a prolonged period, maybe lifelong. It is costly, and also it is very problematic for the patient, but still you have to take it for lifelong. Okay, so here we use the same drugs, but the dose is reduced, and generally we spare cyclosporin. Okay, in place of cyclosporin or tacrolimus, better to use sirolimus. And in case of intolerance, you can use cyclophosphamide or mycophenolate mofetil as the first line drug. Acute rejection, that is if there is there are symptoms of rejection acutely, then the treatment of choice is methylprednisolone. Okay, remember this. You can be asked a 2 marks question on this. What is the treatment of choice, or write the treatment for acute rejection of organ transplant? The treatment of choice is methylprednisolone, which is given in the dose of 0.5 to 1 gram intravenously daily for 3 to 5 days. Okay, or second line drug miromonab can be used along with this. So this was about the immunosuppressants. The questions which can be asked to you in immunosuppressants: short note on cyclosporin, tacrolimus or sirolimus, okay, or short note on anti-D immunoglobulin or anti-thymocyte globulin. The other drugs, they are covered elsewhere. You are asked a short note on immunostimulants, okay? Not routinely, but you can be asked on immunostimulants. So remember the names of immunostimulants at least. Okay, so they are BCG, levamisole, thalidomide, and lenalidomide. Then you have interleukins, that is recombinant interleukin 2. You have colony stimulating factors, GM-CSF, GCSF, and you have recombinant interferons. Okay, so remember the names of these immunostimulants. BCG, it is a live attenuated vaccine from the culture strain, that is strain Bacillus calmette guerin of Mycobacterium bovis. Okay, it is indicated for prophylaxis of tuberculosis, generally given at birth, okay, intradermally, with the help of a tuberculin syringe. 0.5 ml is given intradermally, and that gives around lifelong or 20 years of immunity for tuberculosis. It is also used for prophylaxis and treatment of cancer, that is urinary bladder cancer, cancer in situ of urinary bladder. It is this action is mainly because of the stimulation of T cells and natural killer cells. So the ampule of this BCG, it can be dissolved in 50 ml of saline, and through the help of a catheter, it can be instilled in the bladder 2 hours before urination. Okay, because if the patient urinates, then the BCG also will be washed out. So 2 hours before the urination, this BCG vaccine can be given in cases of the cancer in situ of the urinary bladder. Levamisole. Levamisole is an anti-helminthic drug. Okay, it is used for, as an anti-helminthic drug, levamisole is used for ascariasis and hookworm infestation. Okay, these two types of helminths, you can use levamisole. Mechanism as an anti-helminthic, it is stimulation of the glutamate receptors, and that causes the spastic paralysis in the worms, and the worms, they are expelled live. Immunosuppressant action, it restores the depressed T cell function and also has some action on B cells and macrophages. Use, it is combined with 5-fluorouracil. It is not used as a single drug. It is combined with 5-fluorouracil in the treatment of colorectal cancer, and it is a drug which can be used for vitiligo. Okay, you know what is vitiligo? Again, autoimmune disease where there is skin discoloration, melanocytes, they are destroyed. Okay, so one of the treatment which is available,
pigment producing cells die.
yes, so it can be used in vitiligo. There are many studies which have been done by the dermatologist using this levamisole, where they say that it is effective in vitiligo. Now coming to thalidomide. Okay, do you remember anything about thalidomide?
Yes, sir, thalidomide.
Yes, we remember that thalidomide is thalidomide.
Multiple
Leprosy.
myeloma treatment. Multiple myeloma.
Yes, it's mentioned here, multiple myeloma treatment. Very good. Also used for type
Leprosy.
Yeah,
type 2.
Type 2
It is
leprosy.
not used in leprosy. Okay, it is used for treatment of reactions which occur in leprosy. Lepra reaction type 2, that is erythema nodosum leprosum. Okay,
Yes, sir.
thalidomide you should never forget, because this is the drug which gave us the regulatory system for the pharma industries. Okay, in 1960s, what happened? अभी करना क्लास करो. Okay. So there is a important announcement. Students who have not paid the fees are requested to pay the fees at earliest. So thalidomide in 1960s, it was used as a, what was the use? It was used for morning sickness.
Motion sickness.
Morning sickness, not motion sickness. It was used for morning sickness, right? In pregnant females, it was very much promoted, right? And then what happened after few years? The babies,
Teratogens.
yes, babies which
Got
were
cancer.
born were without limbs. Okay, it was also known as phocomelia. Phocomelia or seal limbs. There were deformities in the limbs. Okay, and that is why this thalidomide was banned. But again, this drug made a comeback, and this time it is absolutely contraindicated in pregnancy. It is used only for multiple myeloma, or it is used for erythema nodosum leprosum. That too, you have to be sure that the patient is not pregnant. Okay, so thalidomide, it inhibits the angiogenesis, also inhibits TNF alpha release, and inhibits the phagocytosis by the neutrophils, and it is a very good immunomodulator used in multiple myeloma and ENL. Aldesleukin, it is nothing but interleukin 2, that is human recombinant interleukin 2, and this interleukin 2, you know, it causes the stimulation of T cells. Okay, the cytotoxic T cells, also the helper T cells, they are stimulated by this interleukin 2. So that is why it acts as a immunostimulant, and it can be used in the treatment of renal cell cancer and melanoma. Adverse effect of this aldesleukin, it can cause cardiovascular toxicity. Okay, why there is cardiovascular toxicity? Because of capillary leak syndrome, where there is leak of water, there is leak of proteins from the capillaries, and that can lead to hypotension and cardiovascular toxicity. There is another drug, that is interleukin 1 11 recombinant, which is used for thrombocytopenia in cases of cancer therapy. When you are giving, if the platelets they have decreased, then you can use interleukin recombinant interleukin 11, which increases the platelet levels. Now interferons, they have antiviral activity, immunomodulatory activity, and they have immunostimulant activity. Okay, so interferons, they were used, or they are used for treatment of many viral infections, right? They can be used in hepatitis B virus, hepatitis C virus infection, and we have three types of interferons which are recombinant, human recombinant interferons, that is interferon alpha, interferon beta, and interferon gamma. So these interferons, they activate the T lymphocytes, natural killer cells, and also the macrophages. Interferon alpha, main use, it can be used for hepatitis B and C virus infections. Okay, other uses, it can be used in CML or non-Hodgkin's lymphoma, hairy cell leukemia, malignant melanoma, or AIDS-related Kaposi's sarcoma. Interferon beta, used in multiple sclerosis, and interferon gamma, mainly used in chronic granulomatous diseases. Okay, so this completes the immunostimulants. At least remember the names of the immunostimulant drugs. Okay, that is BCG, levamisole, thalidomide. Then you have aldesleukin, you have the interferons, that is interferon alpha, beta, and gamma. Okay, so this is all about immunosuppressants and immunostimulants. So this is the classification once again for immunosuppressant drugs. And for this anti-proliferative drugs, go to cancer chemotherapy. For glucocorticoids, go to the lecture on corticosteroids. Okay, TNF alpha inhibitors and IL-1 inhibitors, they have been covered along with the drugs used in rheumatoid arthritis. Okay, any questions? So this is a very simple topic. Short notes, 1, 2, 3. Okay, or a short note on anti-thymocyte globulin or anti-D immunoglobulin. One short note that can be asked to you, you can be asked a short note on monoclonal antibodies, because nowadays this monoclonal antibodies, they are used uh, in therapeutics, and many new monoclonal antibodies, they are coming. Okay, so this topic is covered in general pharmacology, where they have described how monoclonal antibodies, they are produced, right? Uh, that is the desired antigen is injected in the mouse. Okay, and the when this antigen is injected, there will be production of the clone of B cells. Okay, for example, if you inject the uh, antigen A and B, there will be a clone of lymphocytes of B lymphocytes with A and B antigen, and we have to isolate the specific antigen for which we have to produce the monoclonal antibody. This we do by uh, killing the animal, taking the spleen out of this animal, and then these B cells which are obtained, they are pegylated, that is added with